they're asking in relation.
Okay, good afternoon, everyone, and thank you so much for joining today's session in our age-friendly geriatrics education teleecho series. The series is organized for you by UC Irvine's Division of Geriatric Medicine and Gerontology and our Geriatric Workforce Enhancement Program. Again, thank you so much for joining us today. So I want to take you through the agenda. It's as it always is. We're going to start off with introductions and announcements and a welcome, and then moving on into our didactic today on technology advanced geriatrics. And there will be a case discussion as well. And then we'll end with closing and reminders and, some of those surveys and CME surveys that we'll want you to fill out at the end. So stay till the end so you get those links, please. And then just some quick house rules. You have been muted upon entry. So if you have anything to say, you go ahead and unmute yourself. And then when we introduce ourselves, you can go ahead and unmute yourself at any time. If you're talking about any patient-specific questions, please make sure you maintain confidentiality at all times. And then, as you all know, we are CME accredited, and this session is 1 AMA PRA credit. So physicians should claim only the credit commensurate with the extent of their participation in the activity. And then the California Board of Registered Nursing does recognize CME credit as transferable.
I don't think that's a magnetic.
No,
as well.
That's why I have adhesive.
Oh.
Okay. And then this is a project that is supported by the Health Resources and Services Administration. And this information or content or conclusions are those of the author and should not be construed as the official position or policy of HHS, HRSA, or the US government. So before we move on, if you can, please, in the chat, put in your name, your role, your site, and location. We really enjoy seeing where everyone is joining us from. And I'll go ahead and have our hub team introduce themselves. My name is Nika Seville, and I am the project manager for the Geriatric Workforce Enhancement Program here in Orange, California. And I'll go ahead and have Dr. Segal introduce herself.
Welcome, everyone. I'm Sonia Segal. I am a clinical professor here at UC Irvine in the Department of Medicine. My practice site is in Orange at the Senior Health Center. And it's my pleasure to welcome you here today.
Thank you, Dr. Segal. And Dr. Pereira?
Hi, welcome everyone. I'm Manisha Pereira. I'm one of the geriatricians, and I too practice in Orange at UC Irvine. And I also do some nursing home visits too. I care for patients in the nursing home, and welcome and excited to be here today.
Thank you. And PA Valerie George?
Hi, I'm Valerie George. I'm a PA. I work here at the Senior Health Center in Orange with the geriatricians that are listed here. And I do outpatient geriatrics. And so welcome, everyone.
Thank you all, and thanks to our hub team. Looks like we have a lot of people joining us from all over the place, from Guam, from Albuquerque, and Virginia. So thank you all for being here today. I'm going ahead and introduce you to Dr. Julie Rousseau, who is a project scientist in the Division of Geriatric Medicine and Gerontology and a volunteer clinical professor in the School of Nursing. And today she's going to speak to you all on technology advanced geriatrics. Thank you so much for joining us today, Dr. Rousseau.
Thanks, everyone. It's great to have you here today, and hopefully this will be a fun topic. I'm going to go ahead and start by sharing my screen, and we'll begin with a video, and we're also going to have some polling and get some feedback from everyone. Sorry, I will be with you in a second. I love doing technology talks when it takes a minute to get the technology going. So I'm going to start with a little video. Hopefully you can hear this. This is from the Consumer Electronics Show, which is considered the largest tech event in the world. About 120,000 people gathered January 5th through 8th, and I was pleased to join and represent UC Irvine, along with Tom Andriola, who is our Vice Chancellor for Innovation and Research. So this is just a quick overview of what AARP looked like. So we're going to launch a quick poll just to get 5 questions, yes or no, and we'll discuss the results later, but I appreciate everyone sharing their experience with telehealth and technology. AARP began going to CES in 2019, and they had about 400 square feet. This year, they were represented by 7,000 square foot booth with 18 startups and 3 major companies. So AARP was a big presence. It's the first year they've been this big a presence at CES. They held a whole conference with over 20 panels during the Consumer Electronics Show. So their key themes were age tech for self-empowerment, how expanded options for receiving care when and how you prefer, direct, medically accurate, actionable information with continuous complex measurements will help individuals and older adults make informed healthcare decisions. Age tech for health, how telehealth appointments can be from your kitchen with continuous health monitoring biometric devices throughout your house, that older adults are able to access hospital-grade, life-enhancing and life-saving care at home. And smart cities and smart homes using 5G technology, which ensures cybersecurity, as well as fast broadband to receive hospital-grade healthcare and smart homes that help older adults thrive. So these are some of the big themes that AARP shared. CES also hosted a healthcare and technology conference that I was fortunate to attend. A lot of this talk is going to come out of insights from these panels. And as you can tell, the chief medical officer from United Healthcare and Elevance Health, the payer side, were prominent speakers, as well as Teladoc, the AMA, and the American College of Cardiology sponsored a digital health studio where the heads of digital health at Harvard and Yale, CEOs of major tech companies spoke. And again, living longer, aging better, the power of age tech was a theme. This is new. This is new, and it's path-breaking. And you can see that Michael Milken also spoke, as did Seth Rogen, talking about dementia. So just to give you a sense, this is a really new moment in consumer electronics and telehealth, as many of us are aware. So I'm going to ask Nika to share if we have some poll results. Great. So we see about 8% before 2019 regularly conducted telehealth, and 92% did not. And now we see we're about 50%. So 52% are no and 48% are yes. Currently, do you use a digital health integrated device? 40% do and 60% don't. And have you ever recommended an app or a direct to consumer? 64% yes. And do you like technology? This is amazing. 92% say yes and 8% said no. Probably it's self-selecting because you joined today. But if we look at the results from the AMA poll on digital health, we can see that a lot of what you've shared today is what we're seeing nationally. And that last question is really important because when we think about motivation, it's actually not the age of the physician that drives whether technology is integrated, but it's the relationship of the care provider or the primary care provider to technology. So results from the AMA survey, we see this growth across PCPs in definite or some advantage from 31 in 2016 to 47. But if you see also the negative, it went from 14% down to 5%. And the greatest growth was physicians over the age of 51, from 25% to 40% report a definite advantage. And if we include some advantage, we're at 90% currently. Between 2016 and 2020, telehealth visits increased the most. As we all probably know with the pandemic, telehealth represented less than 1%, and that goes along with the poll we just did with you. It was very small uptake, and now more than half of physicians had started using telehealth during the first few months of the pandemic. But we can also see gains in remote patient monitoring and across the board in digital deployment. So why is there adoption? According to the AMA surveys, physicians are liking using digital devices and telehealth as a way to lower burnout rates and to reduce stress. And as I said, it's also about the relationship of the provider to technology. But one of the key motivators is improved clinical outcomes and improved work efficiency. So the pandemic was definitely a catalyst. This is one of the things that moved us rapidly forward. But it's not just the pandemic pushed the industry towards hybrid model in-person remote care, but it also broke down barriers among clinicians, insurers, hospitals, retail pharmacy, Amazon, Google. And as we can see at CES, there's just been a proliferation of health-related technology. The AMA terms this digitally enabled care. And so for today, I've kind of borrowed that and thought of technology-enabled geriatric care. And we're going to focus the rest of the talk on trends and insights from CES. And we will talk about disparity and access, but we're just, and the pandemic certainly brought those to the spotlight, but I'm going to really focus on older adults and access and accessibility. So the bottom line up front, these are your take-home learning objectives. That we've found that consumer to medical grade to clinically accurate devices is the new trend. So we can see EKG or irregular heartbeat sensing and diagnostics are literally in patients' hands through rings and watches. Chronic disease management is becoming seamless from the home to the clinic because there are actionable insights now. App-based coaching is proliferating based on results that are being delivered through wearables. Value-based care is being increasingly driven by consumers. And this is a quote that value-based care, health systems and hospitals that fail to evolve in this manner risk losing their patients to Amazon, Walgreens, CVS, and the health plans and health systems that do embrace digital health. AI, because of the volume of data, if we think about continuous data, we need AI, or as the chief medical officer of the American College of Cardiology calls it, cooperative intelligence. So the volume of continuously gathered data needs management. We need interpretation to drive clinical decision-making. Diagnostics at home is another theme we'll talk about today, as well as smart homes, smart cities. How does this change accessibility and age-friendly communities? And then we're going to conclude with a quick case study from UCI on what we've been piloting and what we've learned. So let's think about, for older adults with multiple chronic diseases, we're seeing the maturation and integration of systems beyond just a single device for a single measurement. And when we think of chronic disease management, we'll start with hypertension. So now we have medical grade technology in the hands of patients and caregivers. Just to remind everyone, this is probably not news for our primary care teams, but in 2021, the U.S. Preventive Service Task Force published a grade A recommendation that said that for best practices, we should be screening in office, but we should actually confirm before management or even diagnostic confirmation through blood pressure measurements outside of the clinical setting. And so we can see that, that this really shifted things. And ambulatory blood pressure, which was considered the standard, has been found to really have temporary sleep disturbance and bruising for older adults. And the trend has really been towards having home blood pressure management. To compound this, of course, the devices that we have encountered when we were training were stethoscopes and Korotkov sounds, but this is technology from the late 19th, early 20th century. And today we've really seen a maturation in these devices. So devices are validated through the US Blood Pressure Validated Device Listing, or VDL. And the devices that you see before you today have all been validated. Some that we'll talk about are not, but I did want to point out that Withings on the left, the Withings blood pressure cuff, is the one that we've been piloting at the Senior Health Center. When we first started our pilot, we had to have a smartphone, but that day has gone. Both Omron and Withings now have cellular enabled devices, and we have an NIH pilot that will be using these devices. They're shipped directly to patients' homes, and all they have to do is take their blood pressure, and it's integrated into the EMR. So this is the trend, is that the devices actually themselves overcome barriers between Wi-Fi or Bluetooth cell phone. But it's not just clinical grade blood pressure cuffs. We also see with Cardia's mobile credit card size at home that it's diagnostic. So this device can diagnose AFib or other cardiac irregularities. Everyone's familiar with what's happened with the Apple Watch. I'm going to talk to some of the future trends around that. So we have blood pressure cuffs that are upper arm, which is the standard, but a VDL approved Omron wrist blood pressure cuff is also available. It's a watch. I tried one of these on. They're really, really comfortable. It's not the upper arm squeeze that you're used to. But it is Apple Watch and some other devices that we'll talk about are going to use a different technology to generate blood pressure readings. So currently the Apple Watch, which has been a leader in a lot of these, can do blood oxygen, it can do ECG app, high and low rate heart, irregular heart notifications, temperature sensing. They've been really promoting that they can track ovulation, not so important for geriatrics, although menopause management. We can see also this SOS, the PERS, that there's a notification for fall detection, crash detection, as well as satellite linked SOS. So increasingly, these devices are in patients' hands. Omron took it one step further this year at CES, and they're no longer talking about checking your blood pressure at home, but they're talking about monitoring and managing hypertension at home to prevent cardiovascular disease. These are EMR integrated AI-driven devices, and VitalSight is the US platform for this. They announced going for zero, and they stated that the next generation won't be defined by age, but by a world without heart attacks or strokes. And this change we see most predominantly in England, where the NHS has been deploying Omron for self-monitoring and self-medication titration. And this was based on the Tasman SR randomized clinical trial results, which showed that this was equal, if not better, to usual care. So if we think of diabetes, what's new in the field of diabetes management? Probably most of you are familiar with continuous glucose management, CGMs. So Freestyle Libre on the right, on the left from Abbott. These use interstitial fluids instead of blood to measure blood glucose, and they're small devices implanted in the upper arm. Dexcom announced G7 as well, and these last, around 14 days, so 2 weeks of continuous data coming in. And they've also linked this with alarms and monitoring. So on the app, it's actually coaching you for diabetes management. Again, not just taking readings, but also helping with management. So there is a wrist one as well that's coming out. These are not yet to market, but again, we're seeing less, not interstitial fluid, but checking light absorption by blood flowing in the vessels to determine glucose concentration. And this has been going on since 2022 when Samsung and MIT announced this breakthrough. But again, it's yet to clear. It's not quite ready, but we do anticipate in the next few years, Apple as well will come out with a blood pressure, a blood glucose monitoring system that's non-invasive. On the right is a really popular trend that I know we're seeing in clinic, which is people using these devices as prevention, pre-diabetic, wanting to get health insights and to maximize their own health. So understanding metabolism, and Abbott is directly linking this to sports and elite athletes. And I think we're going to just see more of this in the future, this dual use where it's being marketed for health improvement and athletes as well as chronic disease management. So Omron's head of research, Daniel McCaffrey, made a pretty bold statement, and I had the pleasure of meeting with him to talk about this, that we need to see a major transition toward integration and overlay of glucose and blood pressure in a meaningful way for the patient or the person who's living at home. McCaffrey said, so the idea now is that you don't have to wear all these devices. I encourage the room and the folks at CES to rise to the occasion of providing a user experience where you don't have to open 20 apps to make a health decision for that day. So medical grade physical exams and continuous monitoring, we're seeing device maturation. And so when we start thinking about telehealth, we really relied on telephones, maybe some video visits, but maybe we sent someone home, we asked them to take their blood pressure. But in terms of physical exams, we really didn't have a lot to work with. And in the space of 3 short years, we've seen quite a bit of maturation in the field. So again, thinking back to the devices that we all trained with to do our physical exams, how does this work with telehealth? So you might be familiar with TytoCare pictured on the right, but there's also this new med wand. They're elegant in that they're in the patient's hands, but they also enable home health or sniff care. These are clinically validated FDA devices, and they enable a full physical exam. A stethoscope is built into it. There's coaching for the patient on how to do it. There's Ultra HD camera for dermatology. There's a pulse ox built in, otoscope, as you can see. These are pretty sophisticated. TytoCare also initially was shipping this to enable remote patient monitoring. Now it sort of has moved into a new that you can replicate your doctor's physical exams regardless of where you are or where your clinician is. Tyto reports an 84% reduction of needing in-person visits and a 70% reduction in ED visits. And they've mainly marketed to pediatrics and working families, but we can see that for geriatrics, for persons living with dementia, for people who have challenges or who are living in assisted living, these kind of direct, and then you can link through teledoc is on the move. If we turn to continuous monitoring or hospital at home technology for transitions care, and we think of medically frail or complex patients where we need a lot of data to simulate what we're thinking of a patient in the bed, inpatient, we get an average of about 4 sets of vital signs. With the new bio button, we get 1,400, and you can see from the screen what kind of data and analytics. Zio Patch also does a lot of this monitoring, but now there are partnerships formed, and this is a partnership between the BioPatch company and AlertWatch, so that dashboards are EMR integrated, but AI is also driving what is going on, making sense of all of this data. And this, again, is new to the market. So let's think about lab at home and diagnostics at home. So when pregnancy tests were first announced to be home, there was a lot of opposition. As we know now, this is kind of a standard that people don't come in for a pregnancy test and then return. That was sort of the leader, but COVID certainly taught us that a lab can exist at home and that we can do testing and screening and self-testing effectively. With that, at CES, this was extremely popular. I should have had a picture, but there were just throngs of people at the Withings booth for the new U-Scan, which allows for urinalysis at home. This little device sits in your toilet and it can test over 3,000 metabolites. So each cartridge has 100 tests, and it lasts about 3 months, and it can track up to 7 individuals or 7 family members. And with being said, we have the vision where you can have a lab at home that won't require any effort or processing, where you have to send something to someone or to collect. It's kind of passive collection. So just think about the use cases for geriatrics, UTI screening, hydration levels, of course, kidney disease and end-stage renal disease management. But for SNFs and at-home monitoring or persons living with dementia, this is kind of a passive way. It only requires using the restroom. These are 2 other companies. Vivu as well targets both customers so that you can see your own health more generally, the theme we talked about. If you're an athlete, you can know your calcium, your pH balance, ketones, and Olive Diagnostics as well also has this continuous monitoring that's preventive health care. So we can see with at-home diagnostics, it's not just convenience and rapid results, but improved access without stigma is what people were talking about. Think about older adults with STIs. This home diagnostics allows for a privacy as well, and it changes expectations that people can get immediate responses like we found with COVID, and they can make their own decisions about whether they want to seek medication or what safety precautions they're going to take with infectious diseases. It also helps prioritize patients who need to be seen, who actually have needs, so you can get patients to the right care more quickly. Genetic testing, of course, at home is another big growth area with personalized and precision medicine. And for persons living with dementia and physical challenges, the ability to ship or have them safely test at home with these new diagnostics is also a positive. So I'm going to introduce this. I have the not ready for primetime players for those of you familiar with Saturday Night Live, and I put them up because they were pretty unknown when they began, and they certainly didn't follow that. The big news at CES, and this is something that there was a large team from the FDA, as well as a big group of government officials. Actually, the chief technology officer from the Senate recommended that I visit this booth. This is investigational, not even close to being cleared. But like I said, who am I to predict? Is that Neurologic is a transdermal optical imaging technology that's from Canada. It was developed in Canada, and it looks at imperceptible facial blood flow changes, and it's captured with a smartphone or the camera like the one that is currently capturing my talk. And it takes a video, and AI drives hemoglobin concentration changes to look at facial blood flow oscillations. There is another company, a French company, Codicy, that is using this as well. So what they're trialing right now, this is not approved. It's meant to just be to know about yourself, but lots of people at CES were lining up to do this. You take a selfie, and it looks at your heart rate, your breathing, your blood pressure, your heart rate variability, your cardiac workload, stress, BMI, and then it also does a lot of predictives including mental health, stress, anxiety. It gives you a score for your risk for different diseases and future health. Again, this was developed out of an intelligence community in order to be able to detect lies. It was a sophisticated lie detector technology that now is being used for healthcare or being piloted for that. So it's important for providers to stay on top of some of these trends, even when they're not yet there, and to think creatively about how to leverage new technologies to improve patient care for older adults and families, so that we can simplify things, so that we can use AI for smart, actionable approaches, to think about empowerment, so that testing and diagnosis also comes along with counseling and coaching, as well as social justice for improving care. And this was a theme at all of them, that Deloitte had issued a report showing that inequality itself costs our healthcare system $320 billion, and by 2040, this will be $1 trillion. And so this accessibility to self-care and to self-diagnosis has the possibility for allowing for more proactive care and personalized care. with actionable insights, or the democratization. So let's turn now and think about smart homes and smart cities, and we want to think about age-friendly. So there is a lot of potential in the technology I'm going to go quickly through, but if we think back to PERS, or personal emergency response systems, which were designed for older adults at home, they had a pretty limited use. It was pretty inscribed. It sort of is like curb cuts. For those of you who know this example, that curb cuts were originally designed for people who were using wheelchairs, but actually now it's used, of course, for everyone with a stroller, or anyone who is trying to engage in e-commerce, Amazon, UPS, the Postal Service, so you get a safe flow of people and goods in urban environments. Charlotte Yeh, the CMO of AARP, stressed that, you know, the idea of devices that just work in the home is not taking into account what the pandemic taught us, which is that mobility and social engagement are required for healthy aging. She said not aging in place, but thriving in motion. And so GPS-enabled devices and wearables are also allowing people to move. And really AARP's, one of their big messages was that we shouldn't be designing things for older adults, but we should think inclusive for anyone who has any kind of challenges. And so this universal design for all, it has been really driving a lot of this technology. So out of smart homes and smart building technology, radar is increasingly moved into healthcare. So this radar technology produces algorithms that process an incredible amount of data. So this is an FDA cleared device for home use and use in SNFs, and it is deployed actually in assisted living. This is Xandar Cardian's sensor, and it detects vital signs 10 times per second. It's a lot of data. So during a 1 8-hour overnight, they can get about 18,000 vital sign data. It was collected, and it can tell you critical notifications like breathing and what's going on with the patient, mobility, are they sleeping or turning. So this is another passive technology that I think we're going to see more of in terms of smart home. Caregiving, along with this radar technology, which was marketed for caregivers as well, to know about those who, as we know, many caregivers live quite far away from the person they're caring for. These are other devices that were connected devices. Smart Fit Wear is being used by PT quite regularly now, so that we can track movement with vests and with wearables, as well as predicted analytics. UCI is a robot, and I am not talking a lot about robots, although robots are fascinating, I'm sorry, or automobiles, a little disclaimer. But BOCO has emotionally responsive care, so that it actually helps sense through interactions, whether or not through speech patterns, whether or not there are issues around emotional health. One of the big showstoppers was that Amazon and Alexa, Google, Siri, and SmartThings have all agreed to use Matter, which is the Connectivity Standard Alliance. So they're going to be interoperable, which is something we've been talking about for a long time, that these devices are going to all have a shared open source universal smart home protocol. I think that's going to drive a lot of change in healthcare as well, as all these devices become bundled and integrated. And to go along with that, Samsung, LG, Panasonic, and Bosch also showcased that their home appliances, as well as their home base, were going to be built through Matter. So accessibility and functional support, this is an area where I spent a lot of time. I think that when we think about persons living with dementia, some of these technologies have a lot of possibility, because we know through our own UCI research projects, it's very hard sometimes to have patients wear rings or wristwatches. So B-Balance on the left is a bath mat. It allows for up to 100 different people to use and to track. They have, it can be connected, it has an 8-month battery life, so you don't have to remember to charge it. And it can give things like weight, balance, posture, again, it's a smart home. It's just integrated into the home. These lace clips and the ashidase are about accessibility. They include a navigation system as well as a GPS. So people with visual challenges, it helps with walking. It will give you alerts, and it'll help along with auditory and other integrated through your smartphone to help you navigate while you're walking. Beyond glasses, so glasses were a big theme. Smart glasses are back. The one on the left actually has hearing built in. It has sound canceling, but also hearing accessibility built into the glass. And on the right, the zero glass is something I think we're going to see more of, because glasses sit on our face and they have contact with our head. This was for seizure related. So it gives you brain activity, body movement, and heart rhythm through the glasses. Hearing aids, as we all know, are big, because in August 16, 2020, the FDA announced that we're going to expand hearing care access. And AARP made they had a big panel on this to stop designing for older adults. If we're putting something in ears, what about expanding the use, having a translator, or making it, as Charlotte Ye said again, an earring as a fashion? And if we think of all the teens running around with earbuds and all sorts of things, designing for that. So it's not something that's stylish, that allows for active lifestyles, and has multi-use. So these are some of the hearing assisted aids that were showcased. And the one on the right, just for novelty, actually had air purifier. So it has no noise canceling, but it also touts that it purifies the air around your face. These are three of my other favorite when I think of persons living with dementia. On the right is a smart toilet, but it not only washes and cleans and helps and blow dries and helps with toileting, it also does the physical lift, so that people who don't have fine motor skills, who have difficulty up and down. In the middle is another really long time coming. This is a 10-second toothbrush. So if we think about how much fine motor skill you need to brush your teeth, this is actually 10 seconds, 35,000 nylon bristles that brush your teeth at once using sonic vibration. And this is available in Europe, and it made its debut in the US and hopefully will be available. On the left is a watch band that's called BeHeart, and it has endless battery power because it's powered by you moving as you move about. And so this can also measure stress, heartbeat, all the other things we see, and it can be integrated with any watch. But again, no need to remember recharging. It just simply works by movement. Robots, not enough time. Sorry about that today. I've favored other devices. The one thing I will point out on the right is this smart wheelchair that's AI driven and autonomous, and it is able to move individuals around. I really wanted to test drive it, but was not able to, but I did get a chance to meet with the people who invented this, and it really is a new day in terms of allowing for people with visual or hearing or other to move rapidly through extremely crowded spaces. In the middle is out of Japan. This is an exoskeleton. It's designed for surgeons. So again, that dual theme. It's meant so that the body has no more weight than when you're sitting. It takes the strain and stress of standing, and it's for surgeons, but you can see again, this has a lot of use cases. As on the left, this is an exoskeleton called Apogee, and it enables you to lift up to 60 pounds with no additional strain, and it protects your back. And so you think about our older adults who are working in warehouse delivery or jobs with lifting. This is an exoskeleton that we may see more of, and that may help in more ways than the original design. So brain health, cognition, and mental health. This is a helmet. It's not the first time it was there. It's called the iSync Wave, and it looks like a bike helmet. But again, it actually measures the electrical activity in the brain. And I think we're going to be seeing more of this going forward, are devices and testing that uses AI for predictive analytics for individuals. Privacy and trust are really, key. Every single speech talked about this, about transparency, that everyone should own their own data. We need more protections, that there needs to be transparency. In research, the ability to share your data for limited periods of time, letting people know how their data is being used. And so the shareability is key, but without privacy and trust, none of this is really going to move forward with our healthcare systems or with the companies. So to try to recap some of this and look at these trends, what are we seeing in this technology that's impacting older adults' health and healthcare? So older adults over the age of 60 have 2 to 3 chronic diseases. And so we really need a better job of closed loop care where devices can predict and inform risks. Alerts and integration can result in actionable clinical response, and that we can have appropriate setting for care for healing, whether it's at home or in clinic or SNF or rehab, hospitals, whether the pharmacy is the place for care. We need to be thinking about triage for settings and urgency. So interoperability and the usefulness of continuous data really relies on us thinking through these changes. As Ami Bhatt, who is the CIO of the American College of Cardiology, said, we need collaborative intelligence, not AI. We need everybody to believe in AI, and that we need to begin to be more reactive, to stop being reactive and to start being proactive and personalized in our care. The dual use cases for innovations that we see with performance athletes for continuous glucose monitoring, unobtrusive wearables, devices that can be used at home, they can be used in a SNF, they could be used in a hospital or in a clinic. Mobility, robotics, and exoskeletons have industrial use, but they also have a profound impact on older adults as we age. Value-based care was really everywhere. Value-based care, of course, right now accounts for about fee-for-service is 70%, 30% is value-based care. But everyone is talking about how, when we think about what matters most to patients, they want value for their care. And there's going to increasingly be consumer-driven changes for value-based care. United Healthcare really talked about this. They're investing $5 billion annually to improve outcomes through value-based care. And when we think of population health with disparities, being able to triage whether someone is appropriate for telehealth or whether they need a community health worker will be important. But remember that Walgreens, Best Buy, Boots Alliance, and CVS are within 7 miles of every human in the United States. And the payer said this is something they can work with. They want to work with this. So this access and value-based care is being driven by payers and by these large healthcare systems. So, for clinicians, are we ready to take the challenge to use this? And one of the things I heard over and over again from chief medical officers are that individual clinicians can't be responsible for bringing data in, nor even, as was said, we're not data experts, but that in partnership, the data can help drive the clinical acumen of our primary care providers to drive decisions and also to empower patients to make the changes that we know they need to. So I'm going to transition and shift gear. I know that was an awful lot of information and a bit of a whirlwind, and that's how CES feels, because you walk and you're being pulled in so many different directions. And I did do the physicians VIP tour, which was a group of about 30 leaders. And it was definitely like that. You would walk from booth to booth and be like, wait, what? As we went through the halls to talk about accessibility and to talk about the future of devices in healthcare. I'm going to shift gears now to talk about a case study. And this is to really bring you into what we're doing at UCI and what we've learned through our own digital health journey and our own digital health initiatives. So Mr. M is a 75-year-old man who presents with uncontrolled hypertension in our clinic for an initial visit. His in-office readings are 165/80, 170/90, and 168/85. And he reports that he has attempted increased exercise and nutrition changes, but he still has persistent hypertension. So if you think about this patient coming in for an initial visit, why don't you put in the chat, and if Nika, if you could, and Dr. Sagal, maybe monitor the chat, knowing the U.S. Preventive Service Task Force guidelines, what do you have to assess for Mr. M? What are some things that you need to know? Give everyone a minute to put some ideas down about what your thoughts are.
Someone said family history and lifestyle. Is he
Right.
taking his prescribed meds? Is he applying his BP cuff correctly? Amount of ETOH, age, medical history, chronic illnesses, family history, living alone, his support system. Is it a wrist cuff?
Great. So, there's a lot here. What matters most is a great way to start. What are his preferences? How does he like to receive care? And here we really want to think about not assuming anything about this patient, really having open-ended. I don't like the word digital literacy. It's what's used in the literature, but really digital engagement. Like, are you comfortable taking your blood pressure at home? I love, is it a wrist cuff? Like understanding lifestyles, making sure that the patient's taking accurate blood pressure reading at home and that you're enabling them to do that. A functional screen, what might limit the use of the smartphone? We learned a lot about small things, that our EMRs are actually Spanish English, but many of our patients didn't realize how to change their EMR portal into Spanish. So trying to think it through some of these access, are they active in the EMR? Do they want to be? Cognitive screen also comes into play. Transportation, how easily can they come back to the clinic? So the social determinants of health, and how are we going to set them up to succeed? So early in the pandemic, we realized that we really didn't have a tool to figure out where people are in their digital engagement. We only knew they were active or are not active, but that didn't really tell us what we needed to know. So we undertook a pilot to see about the digital divide. And just to give you some background, pre-pandemic, 73% of older adults needed help using electronic devices, and 38% of older adults were thought to not be ready for video visits. And 40% of those aged 74 to 91 owns a smartphone. So there's a lot of issues around access and accessibility. So our pilot solution was to build and validate through a rigorous testing a bilingual Spanish-English EPIC integrated tool to assess each patient's digital health literacy, their access, and their engagement. And we built this tool and we have already piloted it. We can assess it through two ways. First of all, it's a 5 to 7 minute screening, like we screen for anything else. And we ask if they've ever scheduled an appointment or checked a lab. Do they know how to message their provider? Have they requested refills? Have they looked at summary notes? How do they access MyChart? Do they have a smartphone? Have they ever done a video visit? And that tells us basically a 1 to 10 scale. So if Mr. M scored a 3 to 5, we would know that if we were going to recommend remote patient monitoring, that we would need to support that journey. Whereas many of our patients in our pilots scored 9 to 10, and it was 10 minutes to get them on board. So the second thing we did was we also had a second validation, which was an EPIC generated auto scoring tool for digital literacy. And this told us whether or not looking at the use of my chart, someone had been very active or not. Had they checked in for a video visit and had they completed a video visit? So like I said, we validated the tool with 20 patients and we had them actually do teach back. So these were quite long visits where we did the tool and then we went question by question to ask them what they had done and how they had done it. Our median age was 80.5, and we were happy to oversample older adults because that's where the largest digital divide is, over 75. We had 11 English and 9 Spanish, and now we just completed, we're analyzing the results. We have about 129 patients that we've done a larger pilot of this to see what we can find about digital literacy. And so if we start with just a screen, the way we screen for most things, then the next thing is how do we have education and how do we overcome access? And we were inspired by the Genius Bar and by Oster and other healthcare systems that have staff. And so prior to enrolling Mr. M or supporting him, we would want to provide education. And to do that, we are opening in April a digital health engagement center or learning center. And this will be a student-staffed Genius Bar with our health professional students from nursing, medicine, public health, and computer science. And they're going to teach whatever patients want to learn. They're digital natives and they're excited. We have quite a good, strong group of medical students and nursing students leading this initiative. So if whatever, we can meet the patient where they are after a screen, and also we can lend them devices. So generally you want to have blood pressure for a week per month, and then circle back. This is one way to kind of titrate and to manage, and you can do this through EMR embedded digital health. So again, there might be a remote patient monitoring order that could be placed. We've built it into our EMR. We can screen with a digital engagement score. A patient can get a referral, or they can walk in and get direct education and support to engage and begin their digital health journey. So as we want to do it as easy as possible to set up. And the way that we set this up was from a pilot study that we completed in 2020 and 2021 in remote patient monitoring, a pilot study. And at the height of the pandemic, when we launched this, we targeted patients who had come in through our HAPS program. And thank you, Dr. Sagel, for your leadership on this. So these are our most complex patients who have many, we looked at our LACE scores. These are incredibly high risk, complex patients. So we did an IRB feasibility study, and Dr. Lee was one of the leads on this study as well. I know she's with us today. And we wanted to ask sort of what would happen to enroll these complex patients in remote patient monitoring. So we had 21 patients successfully complete 2 months. And by this, it was twice-a-day readings. The average age was 82 years old. So we oversampled for our older adults, and the oldest was 97. We had a diverse patient population enroll in this study. And we had full data sets for 20 out of 21. Unfortunately, one of our patients passed before completing the surveys, but she was able to complete the full remote patient monitoring. And we are on the cusp of publishing our results, but just to share with you some of the themes that we learned through qualitative data analysis, that our older adults had a learning mindset, that we underestimated the amount of learning that took place in our intervention. We used student nurses who were able to be research assistants and help our patients, but they reported like they liked learning about labs, and after visit, that learning my chart, they learned how to use smartphone for the first time, and they can access information through my chart. They felt a sense of competency, that they loved learning my chart. It broke down the vitals, readings by day, and it gave them confidence. Most of our patients reported, or our participants reported, having digital literacy improvement. One patient said, I was very new to technology. I only had a home line and my wife had a flip phone. We didn't even have internet, so I needed more instructions on how to work the phone. And we did give them iPhones and Withings blood pressure cuffs in this trial. they liked having a choice. Some of them still really loved Express coming in person. They liked seeing their providers in the front desk, but many of them reported that they liked having a choice, that they felt more comfortable at home and they don't have to worry about the hustle and bustle of getting ready and driving to clinic. They loved the social support. They really felt connected. They liked being able to feel that their vitals were being looked at and that someone was tracking their health and engaged. And health impact was also chronic disease management. Our patients reported that they felt better blood pressure management now, and they liked the calls and the check-in, and they found things that were happening that they may not have known. And that was one of our strongest findings, was this idea that there was a lot of growth, a growth mindset among this population, and that they really did like having the additional social supports. So thank you all for your time. We know that health happens at home and in patients' lives wherever they find themselves, that they're driving change, and we need to see our patients as partners and innovator, that the digital world is coming to healthcare for older adults. We need to curate how helpful and useful that can be. But if we're not part of this process and this conversation, patients may be pursuing this as they see themselves more and more as consumers. And of course, since, as we always point out, that this is a growing field of geriatrics, but there is a decreasing pool of geriatric subspecialists nationwide. And so trying to triage and getting the right patient to the right care, digital health may help us address some of these issues. So thank you all for your time and for joining us today. And we're happy to answer any questions you might have.
Thank you so much, Dr. Rousseau. If anyone has any questions, feel free to type it in the chat. I know we just have a few quick minutes, or you can unmute yourself and ask Dr. Rousseau. But in the meantime, as you're asking questions, please go ahead and you can scan this QR code and fill out the CME form in the session evaluation. Those links will also be sent via email to you. And also just make note of the next sessions that are coming up. We have a lot of great topics coming up through our GWEP grant and our Dementia Care Aware program as well. So thank you so much. And again, thank you so much, Dr. Rousseau and our hub team, for being here, and everyone on the line. We'll stay on for the next 2 or 3 minutes to answer any questions.
I think Nikki had pointed out reimbursement, and absolutely, this is an ongoing issue, particularly with continuous blood glucose. And I think that is about advocacy as we find it useful for our aging populations, but really important point. And that's also about EMR, is that we're not going to be reimbursed for monitoring if it's not integrated into your EMR system. So we've worked very hard at UCI to integrate our remote patient monitoring data. Thanks for your comments. Yeah, I like putting I see that Michael Erickson said about integrating the comfort with tech into geriatric assessment. I think so, because as we're going to self-scheduling and more open scheduling, we're going to create another divide if we don't partner with our patients. So making no assumptions, we were amazed that some of our oldest adults who had a history in the military, or our retired nurses and physicians, our retired engineers, just love this. So that open-ended learning and partnering and meeting your patient where they are and what matters most. So any other questions or comments or ideas?
Okay, thank you so much again, everyone, for attending, and we hope to see you at our next session. We have one on the 17th, focusing on MCI, what it is and how to prevent prognosis. On March 3rd, we have caregivers, advanced care planning. On the 8th, we have nervous system exam and common findings. And on the 10th, we have focusing on caregivers and elder mistreatment. So we hope to see you all there. And again, thank you all. Have a wonderful day.
Thanks, everybody. I appreciate your time.